Okay, thank you so much, Anshika. I'll just show my screen. Yeah. Very good evening to all the expert faculty members present over here. Thank you very much for taking out the time and for attending this meeting today evening. I am Dr. Shilpa Subramanian. I am the medical manager for oncology at Merck Specialties. So Merck is one of the world's oldest pharmaceutical global specialty innovator company for more than 350 years across 66 countries and 1,066 eight founded. Are the slides moving?
No, they are not. Hello. No, they are not moving. Just click on the screen and then try to move it.
Yeah, please just give me a moment. Are the slides moving now?
Yes, they are.
Okay. So today's Med Science meeting basically discusses about the unmet medical needs of patients with MET exon 14 skipping mutation in non-small cell lung carcinoma, as well as a little bit on the evolving treatment modalities, the treatment landscape of MET alterations in non-small cell lung carcinoma patients. So to just touch upon the agenda, so as Dr. Pathak would be joining a little later, we would start off with the session with Dr. Santiago Viteri. So the session is on management of patients with MET exon 14 skipping mutation. Dr. Santiago is a medical oncologist with a degree in medicine from the University of Navarra. His first position as a specialist was at the Mateo Orfila Hospital in Menorca. Dr. Santiago has also worked at the Dr. Rosell Oncology Institute, where he has specialized in cancer molecular biology, personalized medicine, thoracic tumors, and clinical research. In August 2021, Dr. founded the MI Cancer Center in SLP, an independent project dedicated to comprehensive global and personal cancer care for patients and their families. Dr. Santiago has carried out teaching activities, training specialists from Latin America and Europe, and spoken at national and international meetings at conferences. So, Doctor, I would invite you for your talk today. Please give me a moment. I'll be sharing the presentation as well. Over to you, Doctor.
Thank you very much. It is a great pleasure for me to connect here with you. It's 2:30 in Barcelona in the afternoon. I know that you're in the evening. And for me, it's a pleasure to share with colleagues from all abroad, in this case from India, the recent advances in MET alterations for non-small cell lung cancer patients and the exciting new landscape of the possibility to treat them with specific drugs that may suppose a new hope for this kind of patients.
Can you share the slides, please, for Dr. Santiago? We are still seeing the introduction.
Okay, just a minute. I'll just share the screen once again. Doctor, please let me know if my screen is visible.
Yes, I can see it.
Okay.
Okay. So as we were discussing, today's topic, the first of the talks would be about patients with MET exon 14 skipping alterations in non-small cell lung cancer. And for me, I would just like to make a very brief comment on this particular alteration. MET is a very important gene who codifies for a protein that is involved in angiogenesis, in proliferation, and in resistance to many of the treatments we are using now for treating cancer. So when there occur an alteration that creates an hyperactivity of this MET protein, this can be an oncogenic event, meaning that it can drive to a normal cell to become a cancer cell. No? And particularly, there is a little difference between these MET exon 14 skipping alterations and the regular mutations we are used to, for example, the EGFR mutations. No? If we think in EGFR mutations, one mutation causes an hyperactivation of the protein. But here, there are several different mutations that lead to the loss of the exon 14 in this gene. And the exon 14 is very important because it holds the catalytic domain. So it's important to destroy the MET protein when it is not needed in the normal cell. So when these cells lose the exon 14, they cannot get rid of the excess of MET, and they produce a big quantity of normal MET protein. Okay, so what happens when we lose this this exon 14 is that the MET cannot be destroyed and accumulates in the membrane of the cells, and it's very active and homodimerizes and creates a cascade of signaling that commands the cell to divide cells very aggressively. So what does our patients with MET exon 14 skipping alterations look like? Well, what we know is that MET exon 14 can be detected in 3 to 4% of patients with non-small cell lung cancer, and it happens in all histologies. It's not only in adenocarcinoma, as you will see. And it's particularly enriched in a very rare type of non-small cell lung cancer, which is sarcomatoid cancer, which is very aggressive, and it has a high percentage of MET exon 14 skipping alterations. The second thing is that generally are older patients. The mean age of non-small cell lung cancer patients with MET exon 14 skipping is around 72, something like that. You will see later. It doesn't care about the histology, as we said, and it doesn't care about smoking history. 50% approximately of the patients have had previous history of smoking or not. So it doesn't influence the possibility to have these mutations. And also it happens more or less equally between male and female patients. There is a very interesting feature here, that is the PD-L1 expression is very common in this kind of tumors. You can see that about 50% of these patients will present with more than 50% TPS expression of PD-L1. And this is important because when we diagnose a patient, we see it for the first time and we receive the molecular results, we may see this high expression of PD-L1 and we may be tempted to use immunotherapy, anti-PD-1 or anti-PD-L1 checkpoint inhibitors. But the problem is that this high expression doesn't have the same predictive meaning in patients that also harbor MET exon 14 skipping, that they don't respond very well to immunotherapy. So for at least in my practice, one of my problems is that I usually receive the PD-L1 result very fast, and I take a little more days to receive the NGS, the testing of the mutation. So you need to be patient, don't rush, wait until you have all the results before deciding to start the treatment if the clinical characteristics of the patient allow it. Well, as we can see, this disease, these are retrospective data, but this disease seems to be more aggressive than other kinds of non-small cell lung cancers. You can see in the graph that is in the right part of the screen, the overall survival of this patient is very reduced compared to other patients, and this is because a particular aggressivity of this disease. I have seen patients with presenting with bone metastases, a lot of pleural effusion, also peritoneal carcinomatosis that is not so common in lung cancer. So this kind of presentation is not rare in MET exon 14 skipping. The next slide, please. Can you please put the next slide?
So just a minute.
Yeah.
I think there's some issue.
Maybe I can control. Yeah.
Please give me a minute, sir.
Shilpa, let me take it over. I'll just share my screen, please.
Yeah.
शिल्पा, वो स्क्रीन जब हम स्क्रीन शेयर करते हैं ना तो वो लॉक हो जाता है, तो आप उस पर टैप करके करोगे मूव तो वो हो जाएगा।
Okay. So as we were discussing, these are it's an aggressive kind of disease, but also it's a disease that does not respond well to standard of care treatments when we compare to MET inhibitors, that we will see later. No, when you see the PFS of patients treated with immunotherapy, even when they have, as we explained, high expression of PD-L1, the median PFS is short, 2.69 months, and patients progress rapidly. And also the same happens to chemotherapy. As you can see in the other graph, the overall survival for patients with treated with chemotherapy is only 8.1 months compared to 24.6 months in the when the use of MET inhibitors. So this is a very important thing. I mean, MET exon 14 is a driving alteration, an oncogenic driver alteration. And if we can block it effectively, we may obtain the most benefit for our patients, while regular therapies like chemotherapy and immunotherapy do not seem to perform well in this setting of patients. Please, the next slide. The next. So what types of MET inhibitors do we have currently at our disposal? There are 3 types, and the type of inhibitors are classified depending on the way they bind to the protein and the part of the protein where they bind. No? Type 1 inhibitors are ATP competitive and bind specifically to the activation loop of MET. Type 2 inhibitors do more or less the same at the ATP competitive and bind specifically, but they have a bigger molecule and they bind differently. And as you can see, most of these inhibitors, they also inhibit other targets. That's important. They are like multi-kinase or dirty inhibitors. And type 3 inhibitors are non-ATP competitive, but are not currently in development at this moment. So if we look again to the type 1 inhibitors, we will see some of them that we already know. Crizotinib, it was tested for ALK and then also approved for ROS1, and it has an activity against MET, but not so potent, not so specific as the new drugs that are being developed and that now have approval, like tepotinib or capmatinib. Okay, next slide, please. Okay, we compare these new MET inhibitors that we have available now. We can see this, as we say, like the mechanism of action. Mainly, I will concentrate on tepotinib and capmatinib, which are the most available now. Both are type 1B, reversible MET TKIs. Both are highly selective. They mostly only inhibit the MET. They do not have other important inhibition of other kinases, and this is very relevant for the safety profile, the toxicities, no? And the dosing in the case of tepotinib is once daily, and the capmatinib is twice daily. And both of them have shown some brain penetration, although tepotinib seems to have a more important brain penetration. Please, the next slide. Well, these drugs have been tested in phase 2 trials, and these phase 2 trials have led to the approval of this drug. So this is interesting because we haven't had the typical phase 3 trial comparing to standard of treatment, and this is because this rare alteration would be very difficult and very long and time-consuming and expensive trials to be done, and particularly the efficacy that we see in this phase 2 trials is significant. So it's been approved also in Europe and in the United States. So the main interesting thing is that the Vision trial included 313 patients it had two cohorts. The first cohort was the metexon 14 skipping alteration. And for me, one of the very nice features of this trial is that it allowed patients to be included regardless if the mutation was detected in the tumor biopsy or by liquid biopsy. Okay, so this is very interesting because it allows you to, in your practice, if you can use liquid biopsy, or if you have a patient where tissue is not available and you detect this, you will know that the efficacy is the same, no matter if you detect it in the liquid biopsy or in the tissue. And then they reproduce cohort C, which is a confirmatory cohort. No, so they have like 113 patients in the first cohort, and then they repeat the second cohort to confirm the results. And the characteristics, as we discussed, no, you can see in the chart that the median age is, as we said, 72 years old, more or less, that around 50% of the patients were male. The smoking history is around 50% again. The different histologies we represented, for me, particularly interesting, the squamous, no? Because when we face in our clinical days, when we visit squamous cell carcinoma patients, we know that we don't have much access to targeted therapies, but they may harbor metexon 14 skipping alterations, and they can benefit. And also, as you will see, around 20% of the patients had brain metastasis at the baseline. So this is typically a disease that is oncogenic driven. No? For the next slide, please. Well, here I wanted to summarize a little what I think are the key publications in the development of these new drugs and the knowledge of this disease. And it always strikes me, no, because when we start to see the results, we think that is something very new. No, but you can see here that the first report of meta-amplification in non-small cell lung cancer was published in 1996, and the metexon 14 skipping alterations were recognized as an oncogenic driver for non-small cell lung cancer in 2005. And one of the exciting things of the current times is that the development of the new drugs and it's quite fast. No, you can see that reports of crizotinib being active in meta-amplifications were published by Dr. Ignatius in 2011. And in 2015, crizotinib and cabozantinib, there were reports of activity in metexon 14 skipping alterations. But the recent approval of two specific inhibitors, very selective and very effective, tepotinib and capmatinib, were published simultaneously in 2020. Vision trial for tepotinib and geometry trial for capmatinib. Next slide, please. Okay, so again, we will try to summarize a little the efficacy data of these trials. Of course, you know that we cannot compare face-to-face, but just to have a general idea of the activity of these drugs, you will see that mainly they differentiated if the patients were naive to treatment and were treated in the first line, or if they were treated in second or further lines. Okay, and also we have a split here with a column for the ASIAN patients. No, so it will be a little more adapted to your reality. No, so here you see that the median PFS, overall median PFS for tepotinib in the first line setting was 16 months, 15.9 months, and the median overall survival was 29.7 months, which is a very impressive figure compared to what we've seen that happens with the standard of care treatments in this population, and with a median duration of response of 46.4. Okay, and 58.6 overall response rate. So these are the characteristics or what we can obtain when we use tepotinib in the first line setting for patients that have never been treated. If we compare this with the Asian subgroup, we can see that it's mostly reproducible. Okay, practically the same result. So we don't see any particular difference if we look at the data of the global population of the trial or if we look at the Asian population. Let's go to the capmatinib, and then we will look at the second or further lines. And what can we see in the capmatinib trial? Median PFS of 12.5 months, median overall survival of 25.5, and an overall response rate of 68.3. Okay, these are very comparable. We are not face to face comparing, but it looks a very similar yielding of these medications. But the main interesting difference, and that we cannot explain with maybe due to the population, different things, but is that the median duration of response in the capmatinib trial was only 16.6 months compared to the 46.4 months that was detected in the tepotinib trial. Okay, and the savolitinib trial is a small trial. It only has 70 patients, and it was also patients were enrolled by tissue positivity, and the results were a little not so exciting. I mean, you can see the median PFS is only 5.6 months. The median overall survival is 10.9 months, and the overall response rate is 46.4. So, well, it seems to be a little lower in potency compared to the other trials. When we look at what happens in the patients that were treated in second line or further lines, what we will see is that there is a slight decrease, of course, of the efficacy. No, it's logical, but in fact, it's not so different. So one of the interesting things in the tepotinib trial is that it seemed to have a very similar activity regardless the line of therapy you use. What led European agencies to approve only in second line, which is very, very disappointing for us as doctors, because we know that you have very good results in first line, but they were claiming that with the lack of a phase 3 trial in the first line setting, they prefer not to give the full approval. But in the United States and in many other countries and in Asia and India as well, you may use it in any line. Here, the main change is also in the duration of response that drops from 46.4 if you use it in the first line to 12.4 if you use it in second or further lines, which is, of course, understandable if you think that the tumor after is exposed to different treatments may develop different resistant mechanisms. And the results in the Asian subgroup is similar. And if we'll have a look at what happens in the capmatinib trial, we can see that there's a drop in the median PFS. There's a drop in the duration of response as well. Although the median overall survival seems to remain almost unchanged. So this is interesting when we have a drug that is very active. It's active in a difficult population. It's active in first line and in further lines. But if you have the opportunity to use it in the first line and you have the diagnosis, there are reasons to think that it's a very good idea to use it from the beginning. Next slide, please. Okay, this is more or less the same. It tries to summarize the different trials and the different inhibitors, but in a more graphical way, no? The area of the circles is the number of patients included, no? And I like this because you visually can understand that the important effort that has been done with tepotinib, including more than 300 patients. There are two spheres for tepotinib and capmatinib and savolitinib because we are splitting first line versus further lines. And you can see here the median progression-free survival obtained in the vertical axis and the horizontal axis. You can see the objective response rate. So I think, well, it's an exciting landscape. We have at least two available drugs to use for our patients with MET exon 14 skipping. Next slide, please. Okay, this is the design of the vision study. I already explained it to you more or less. It was a single-arm phase 2 trial. Patients enrolled had advanced or metastatic non-small cell lung cancer, the exon 14 skipping positive, regardless liquid or tumor biopsy. No prior targeted therapies against MET, and first, second, or third line patients could be included. And there were two cohorts, one cohort of 152 patients and the confirmatory cohort with 161 patients. So in total, we have these more than 300 patients that were treated with tepotinib 45 milligrams every day. And well, you can see that we analyzed them separately if they were naive or previously treated. Next slide, please. Okay, these are the characteristics of our patients. I will not go in detail because more or less you will see it's what we explained. Older age, I want you to have just a look at the range. No, there are patients included with 94 years old in the first line and 89 in the second line. And for me, this is very interesting because sometimes when you have a patient in front of you and it's an elderly patient, you may think, oh, maybe this patient is not fit for chemotherapy, etc. No, and probably I cannot offer him anything. But you need to know your diagnostics, your molecular diagnosis, because if he has an oncogenic mutation, and particularly if he's elderly, he may have a higher risk of having MET exon 14 skipping. He may really benefit from this. So it's worth testing, doing the precise diagnosis to be able to decide the treatment. Male or female, smoking status, and histology are more or less as we explained. Okay, so and both groups, first line or further lines, were similar in all the aspects. Next slide, please. Okay, here you can see the efficacy data in naive patients that were enrolled in the vision trial. We already explained that, but now you see the curves, no? 46.4 duration of response. This is very impressive, particularly for patients that usually when they present at your clinic are very symptomatic. Okay, the PFS is 12.6 months and the overall survival 20.3. But if you see the waterfall plot below, you can see that most of the patients have reductions in their tumors, and the overall response rate, I mean, reductions in more than 20% of the diameters, is for almost 60% of the patients. Okay, so it's a very, very active in the first line setting. The next slide, please. And when you look at the, okay, this is more or less the same, but in the, what's the difference in this slide? Sorry, treatment controlled by division via tumor biopsy. Okay, this is when we look only the ones that were positive in the tumor biopsy, in the tissue, not in the liquid biopsy. And as we said, tumor shrinkage, 90% of patients, irrespective of lines. Okay, and if we see here, the overall response rate is a little better when we look those patients that were positive in tissue. Okay, next slide, please. This is the patients that were positive in previously treated patients. As we discussed, the median duration of response drops from 46 to 12, but the PFS and the overall survival more or less remain quite good, and the overall response rate and the waterfall plot showing this decrease in most of the patients. Next slide, please. Okay. This is the same, but for previously treated patients. Okay, next slide. Okay, if we have a look at the Asian population, what we can see is that the results are quite consistent, comparable to the overall population. We can see an overall response rate of 60%. we can see that the median duration of response was not so impressive in the first line. We were seeing the 46.6, and here in the Asian population is 20.7. But the median PFS and the overall survival have a very, very good numbers, with a 32 overall survival, 32 months median overall survival for Asian patients, and 23 in patients that were previously treated. So this is quite good. And as you can see here in the right, all the subgroups seem to have similar benefit. Next slide, please. Well, an important issue is that that's fine that we can stop the disease of our patients, but we need to know if our patients feel better or that the side effects or the toxicities of our treatment doesn't impair their quality of life. And a very extensive study of the quality of life of patients was done during these trials, and we've seen that the patients had stability in their quality of life over time, all these months on treatment, that did not cause an worsening of their quality of life. And in the next slide, please, we can see that for these patients, some of the symptoms that are related to the lung cancer disease improve, particularly clinically meaningful improvement in cough. Okay. Next slide, please. Well, this is a little summary of my own experience with tepotinib in MET-altered patients. I have been able to treat myself 17 patients, as you can see, well, 11 men, 6 women. The median age was 66-year-old, but this is because I also include here patients with MET amplification. And you will see that this oncogenic alteration doesn't have the same characteristic of MET exon 14 to be in elderly people. MET amplified patients are a little younger, and those patients were treated in the Vision trial, 8 of them in a program of early access, and one of the patients is treated in a standard of care now that we have the tepotinib available. And when we use it also for patients with MET amplification and for patients as a primary driver, but with patients for MET amplification as a resistant mechanism to other drivers that we can discuss in the next session. Until now, the patient that is still ongoing, one of the patients is still ongoing and has a duration of response of more than 25 months with a very good tolerance. Next slide, please. Well, so how efficacious is tepotinib in patients with brain metastasis is a very important question. We can remember that almost 20% of the patients presented with some sort of brain metastasis in the trial. So in the Vision trial, 57 patients had brain metastasis. And when we compare the efficacy outcomes, we see that they are more or less the same in the patients with or without brain metastasis. I mean, overall response rate is similar, duration, disease control rate is similar, duration of response is shorter. Of course, patients with brain metastasis is more aggressive, but median overall survival is similar between patients with or without brain metastasis. This is an indirect way to analyze if the brain metastasis have an impact in the efficacy of the treatment. But in the next slide, we can see that there were 15 patients with metastatic brain metastasis that were available for a response, okay, by the criteria, RANO-BM criteria. 12 of the patients had received prior brain radiotherapy, but we could see specifically intracranial overall response, okay? So you can see a 66.7 overall response rate of brain metastasis. So that's very important. We need to know that our drugs are active in the brain. Okay. Next slide, please. tepotinib and capmatinib in patients with MET exon 14. Okay, so these are the two drugs we have available in reality, no? And there are two phase 2 trials, similar designs, different cohorts. They tested for first line, for different lines, similar populations, at least as a first glance. So how do we know? How do we know what kind of treatment do we choose? No, well, we haven't had a direct comparison, but we can do statistic comparisons. No, what is called a MAIC, a matching adjust indirect comparison. The next slide, please. Well, so in the MAIC, we tried to evaluate both trials, like equalize them to be able to compare them and to eliminate possible confounding factors. So what we see is that, well, there was a previously published MAIC that was published a couple of years ago, and it showed a prolonged PFS and overall survival of tepotinib compared with crizo or capmatinib, but this data have been updated with the latest cutoff point of the Vision trial in November 2022, and the latest data we have from the Geometry trial. So. And the cutoff point in the Geometry is the January 22, the last published one. Okay, so please, the next slide. When we try to compare these trials after this statistic equalization, what we can see here is that the weighted median PFS for tepotinib would be 22 months of PFS compared to the 12.3 in the capmatinib trial. And if we look at the overall survival, we will see that the weighted median overall survival is 29.7 compared to 20.7. Okay, so this is, of course, a mathematical analysis. We are trying to compare different populations that were included in the trial, but we try to remove all the potential confounding factors and have a real feeling of if there is any superiority in one of these compounds. And the MAIC offers us a potential trend of superiority of tepotinib compared to the capmatinib. Next slide, please. Here you can see the same, but for previously treated patients. And again, the trend of the analysis shows that there would be more efficacy in PFS and overall survival for the tepotinib trial. Okay, the safety of the MET inhibitors. Next slide, please. How I'm on time? Maybe I'm a little delayed. I'm not sure. Okay, so well, a very interesting thing is that these are very specific MET inhibitors that we've seen. No, they don't inhibit other kinases. So the safety profile is very, very similar, very reproducible between all these drugs, because they do have the same mechanism of action, and they block the same proteins, and the side effects are very reproducible. No, the main side effect that we see in the real practice is the edema. Okay, and we may want to explain a little bit about this edema, but it seems to be a class effect of all MET inhibitors, even all other MET inhibitors that are not TKIs. For example, amivantamab, they also have this effect, and this is probably related to an effect of the drug in the MET protein that is present in the endothelial vascular cells. Okay, so we are blocking the MET in the tumor, but we are also blocking the MET in the endothelial cells. As you can see, edema is very frequent for tepotinib, 67%, for capmatinib, 64%, and for savolitinib, 56%. But higher grades, I mean, severe edema is not so common, 11.2 or 13.1 or 9. And it's usually manageable. I mean, it may lead to reduction of dose, it may lead to drug holidays, and it can affect a little the quality of life of the patients, but it's not dangerous side effect in most cases. Then you may have a little nausea, ALT increase, which is very similar in other TKIs. Interesting, this creatinine increase, no? The creatinine increase is not because of kidney damage, okay? It doesn't seem that these drugs can cause a damage directly into the kidney, but because it interferes with a protein that transports the creatinine. So we can see this like artificial elevation of creatinine in the blood test. Okay, but the problem is that sometimes it's difficult to discriminate if this is a creatinine increase caused by this effect of the drug or a real renal insufficiency. So sometimes it's recommended when you suspect that a creatinine increase you see in one of your patients and think that they may be elderly patients, they may have other comorbidities, etc. And maybe when they have edema, you use diuretic drugs. So if you start to see a creatinine increase in your patients, you may need to use a different blood test to detect the renal function. For example, urea clearance instead of creatinine clearance, because urea clearance is not affected by this problem of the drug. We've seen also some hypoalbuminemia that also may have a relationship when you try to deal with the edema. But the main important thing is that these side effects were not a cause or an important cause of discontinuation. Many patients could continue the treatment. Around 15% of the patients had to discontinue the treatment because of the side effects. Next slide, please. Okay, this is what I was telling you, no? Edema may have many causes. The reduction of the plasma oncotic pressure, the increase of the capillary permeability, etc. But we don't really know if this edema is vascular or lymphatic or probably mixed, okay? So what we think is that, well, we know that edema is the most frequent adverse event in MET inhibitors, that this edema may be mixed, vascular and lymphatic, and may not be immediately symptomatic, but it's very important to be proactive against it. I mean, it's better to prevent it than to treat it when the patient has an important edema. In my case, I usually recommend the patients to do a measurement of the weights daily, that they write down their weights every day. And if we
an unexplained increase of the can you hear me? Because I think I ran out of the
Dr. Santiago, we were.
okay, just a second. Here. Okay, so as I was saying, it's important to explain the patients that they may have this retention of liquids. It's important to let them understand that physical activity is a good way to prevent this side effect of the edema, and it's important to detect it early. Because once it's very well established, the patient can come with very swollen legs or and sometimes when it's very well established, difficult to improve it. So it's much better to prevent it and to be aware of that it can happen, and it happens in many of the patients. And sometimes it can cause some difficulty to discriminate between edema, even it can cause pleural effusions or ascites, and sometimes it's difficult to discriminate between progression and a side effect. So if you see a pleural effusion, for example, my advice is always to analyze it, try to understand if it's malignant or caused by the toxicity. The best treatments can be physical therapy, like massages, draining lymphatic, etc. Physical exercise, as I said, diuretics can be helpful partially. I recommend rich protein diet, rich in proteins and low in salt. And also very important to analyze other potential causes of edema, because these patients may be diabetic, hypertense, etc., no? So it's important to manage this to avoid interruptions of the treatment. Next slide, please. Well, I think I have just explained more or less this. If you have like grade 3 edema, you can interrupt the drug until the edema improves, and then you can restart with a reduced dose. No, in the tepotinib, there's the possibility to reduce to 22 to 225 milligrams per day. Okay, and of course for grade 4 and toxicities that suppose a risk of life, then you can stop the drug definitely. Next slide, please. Okay, I already explained you about the creatine increase. It is supposed to be because of an inhibition of the renal tubular transporter protein, and it may be, it is not, I mean, something that we need to worry about, but we need to discriminate if this is a real damage of the kidney or not. Next slide, please. Well, the same. And as we were saying, the important thing is to try to measure the renal function with a test that does not include the creatinine, but for example, the urea clearance is an opportunity. Okay, next slide. It's not very common, in fact. This is again a visual summary of the side effects: peripheral edema, hypoalbuminemia, pleural effusion. This is an interesting article. It's for management of all MET TKI inhibitors. As an oral medication, all of them may have some gastrointestinal disturbances like nausea or diarrhea, but it's not usually a problem. You need to check the transaminases and the liver function. That can be a little elevated, but it's usually also don't have any problem. And regarding the interstitial lung disease, is very rare. Okay. But as with any TKI, if the patient starts having cough or dyspnea of rapid onset, you should rule out this, no, with a CT scan, etc., and stop the drug until you understand what's happening. Next slide. Next slide. Well, in summary, there's been an unmet need for patients with MET exon 14 skipping. I want to remind you that they were firstly described for non-small cell lung cancer in 2005. Now we have very effective drugs like tepotinib that demonstrated a robust and lasting efficacy in treatment-naive patients and in previously treated patients enrolled in the VISION study, including those with brain metastasis. The results were very similar in Asian population and the overall population, and the patients could be enrolled by liquid biopsy or tissue biopsy. And that when we want to compare this with the main competitor we have now in our possibilities to use, the capmatinib, we don't have a face-to-face. There haven't been a direct comparison, but we can try to do indirect comparisons, and so far the indirect comparison seems to have a stronger benefit for the tepotinib in comparison with capmatinib. And regarding the side effects, the main issue you will really have when you treat your patients will be edema. And my advice is to explain the patients, to rely on your nurses also to be able to detect this edema early.
Thank you very much for the wonderful session, Dr. Santiago. It was indeed very insightful. Very good evening, Dr. Pathak.
Yeah, good evening.
so
Sorry for joining late, but I could get most of the talk of Dr. Santiago. So very heartening to know that there are now effective drugs to target this rare but a targetable mutation. So we can have a couple of questions, and one from my own side would be, since most of these patients are old and have comorbidities, and sometimes the clinicians feel that there is a need to have rapid response. So how fast this drug acts?
It is very fast. I mean, this is the kind of effect that you see with other targeted therapies that probably when you do the first CT scan after 6 weeks or 8 weeks, you already see the responses. I mean, the median time for response is around 6 to 8 weeks. But also clinically, the patient refers the benefits in the first days. I remember many of my patients, when you start the treatment, and after 1 week having the drug, they say, no, I now breathe better, I have less pain, etc. So this is this kind of very, very fast response.
That's it. So even patients who are on some kind of supportive care like oxygen, would they come off the oxygen support with this drug very soon?
Yeah. In fact, I have one of the most dramatic cases I treated myself was a patient that was treated with chemoimmunotherapy in the first line. It was a younger patient. He had like a 56-year-old, but he started with a very, very aggressive and extended disease. He didn't respond to the first line, and he was referred to the palliative care and about to start like a palliative sedation with an important need of oxygen, etc. So then we realized that he had the metexon 14, and we decided to start the oral treatment even when he was hospitalized, ICOG 4 probably. And 1 week after, he didn't need the oxygen. So it was so surprising from seeing him in the bed very, very ill, and 1 week later he didn't need the oxygen, and later he was walking, etc. So it was this kind of what they call Lazarus responses.
Great. So there is a question in the chat box. Do we observe this mutation in other cancers other than lung cancer where this drug could work?
Excuse me, I am not sure. Other kinds of lung cancer, and if they harbor this.
Other than lung cancer, do any other cancers, have you observed this mutation?
Well, in fact, MET amplification is largely seen in other cancers, gastric cancer, etc. But for the MET exon 14 skipping, I'm not aware that it's very frequent to detect this in others. Probably it can be. No, I wouldn't say no, because, for example, ALK fusions can be seen in many other types of tumor, rare tumors like myofibroblastic inflammatory tumors or others. And ROS fusions are also seen in different tumors. But to be honest, I'm not aware of, in particular for MET exon 14 skipping, I'm not aware that it's at least common or recognized in other tumor types. Maybe any other of the colleagues in the panel may know, but I only know it's well described in non-small cell lung cancer, and particularly in sarcoma type subtypes,
Okay.
but not in other tumors that I know of.
All right. So thank you, Dr. Santiago, and I can see Dr. Bishwas. So Shilpa, shall we go ahead with Dr. Bishwas' presentation?
So we would go ahead with Dr. Ashish's presentation.
Okay. All right. So Dr. Ashish is a colleague, and he heads the medical oncology department at CMC Vellore. Welcome, Ashish. And
Hi, good evening, sir.
Presentation. Good evening. Yes.
Good evening,
Please go
sir.
ahead. Yeah.
So thank you, Professor Santiago. That was really useful, and you took us through every details about this disease and this drug. So thank you, Merck, for asking me to present one of my experience with this drug and one patient. And I'll keep it brief because we have a panel discussion to follow. So in my next slide, you will see this was way back in May 2022, where one gentleman was he was a 62-year-old recently retired mechanical engineer, very smart person who just felt that he couldn't find words when he was speaking and his speech was slurred. And so with these complaints, he came in and he was evaluated in under neurology. And he also gave a history of smoking for the last 30 years. Other than that, he was extremely fit. So his imaging of his brain, what you see in his next slide, did reveal that the reason for all his symptoms was actually a lesion which was sitting in his left frontal lobe. And this lesion was enhancing, and there had some necrotic component in it. And the same MRI also picked up small but two other lesions. And it was very faint, and but there was one lesion in the right superior frontal gyrus, and another one was near the pituitary gland. So then began the search of the primary, and subsequently, because this looked like a metastasis, so he had a PET scan. And PET scan did show a lesion in his left upper lobe. You can see that this is quite a big lesion, but asymptomatic. The same PET also showed he had a lymph nodes and the hilar, subcarinal, and contralateral hilar nodes. So locally, this tumor was staged as T3 and 3. No other bony or visceral metastasis except for the brain lesion. So in view of it is metastatic disease, and a core biopsy from this was reported as adenocarcinoma. And it had a signer. Immunohistochemistry was TTF1 was positive, negative for P40 because he was a smoker. We want to rule out squamous cancer. In our center, we do EGFR and ALK. EGFR by PCR, ALK by IHC, and we got the report pretty soon, and both of these were negative. So go back to the scan. One slide. Go back. Yes. So now looking at his clinical picture. So obviously the first plan was to treat his brain lesion because that's what was making him symptomatic. And then he was discussed in multidisciplinary tumor board meeting with the radiation oncologist, with the neurosurgeons. Should we go after them surgically? Now, because if this was a solitary lesion, that's what we would have preferred. But because there were two other smaller lesions, even though they were very small and picked up only because of the MRI, the neurosurgeon said maybe it's better to treat with radiotherapy. And by then we had EGFR and ALK report, and then the question was whether should we use whole brain radiotherapy, or should we use SBRT or stereotactic radiosurgery? And so generally if we have a driver mutation, we would not do whole brain radiotherapy because we know that some of these patients can live long, and he's a smart engineer, and he would not want any cognitive decline in the near term. But in this situation, EGFR and ALK was negative. Still, for some reason, we thought, let's just do SRS. And he had SRS for two lesions in the brain. Near the pituitary, that lesion we did not treat because it was very small. And then we looked at the PDL1, which was 30%. So a smoker, adenocarcinoma, PDL1 positive, with immunotherapy, and that's what we started for him after the SRS. And after four cycles, we did imaging again. Just next slide. Next slide, please. Next slide. The imaging slide. Next slide. Yes. So imaging here again, if you see that he actually no, this is a recent scan. Do we have a brain imaging next in the next slide? Okay, we don't have that. So, so go back. Doesn't matter. So I wanted to show you another MRI just to show his response. Go back, please. So what I was trying to tell you is that he did responded really well as a result of radiotherapy, and by then we had send off an NGS panel because that's what we do for most patients, and it had come back as a MET exon 14 skipping mutation. So again, at the end of 4 cycles, he's better. His lung disease is stable. Brain disease is under control. The question was, should we just continue pemetrexed maintenance? And now in the presence of this MET exon 14 skipping mutation, what's the role of continuing checkpoint inhibitor maintenance? Now, if you would have responded really well in the lung, I would have probably waited to start on a TKI. But always at the back of our mind, it's always there that we have not done a whole brain radiation. And we know efficacy of some of this chemotherapy may not be great in the CNS. So putting it all together, we decided to kind of get hold of this tepotinib so that we give him the best drug as early as we can. And thankfully, by then, this was 22, so the drug was just coming into the India, and so we applied for a compassionate access, and it was approved, and he was able to start on tepotinib. So next slide shows you the response after tepotinib, right? And if you see the mass has really shrunk in the width, but the length remains almost the same. So as per RECIST, they would call this stable disease, but you can clearly see that he is responding in the lung. And this was after that he had stable disease on chemoimmuno. So this just tells you that the drug was working. Now, as expected, even after he was told about edema, he came in May 23. This was almost about 8 to 9 months with significant edema, and he gained almost about 10 kilos of weight. And I don't know if you can make out, if you compare the subcutaneous tissue in this CT versus the CT I showed you, there is a lot of weight gain, which is just edema in the interstitial space. So initially we said, okay, compression therapy, limb elevation. I told him this is just a cosmetic effect. As Professor explained in his talk, it doesn't mean that you've got a renal or a liver hepatic injury or a cardiac injury. But still, it was becoming difficult for him. He couldn't wear his footwear. He had problems walking long distances. So I had to kind of use a small dose diuretics for him for a short time. Didn't want to continue diuretics for long because of diuretic-related issues. So, and then ultimately I had to reduce the dose of 450 on one day and 225 on alternate days. I wouldn't say it addressed the problem completely, but at least the edema became manageable. So this is a recent scan, and he's doing pretty fine. We are able to avoid whole brain RT for him altogether. The response in the CNS is ongoing. Now, the question which usually comes up with these driver mutation patients are like, do you offer them local treatment now? That because it's always there in the back of my mind that, okay, the PFS, what we see is about a year, OS for about 2 years. Now, this is being a rare disease, a rare situation. We can't expect large data to guide therapy, but that's probably something which we can take up in the panel discussion. So next slide. Yeah, so I will stop there. So points to learn from this patient was, number one, you should always expect this mutation in all histologies, especially in smokers, especially in older people, right? You should get the NGS done as early as you can. The first line treatment still remains chemotherapy with or without immunotherapy. Even in the presence of brain disease, as even Professor showed in one of his slides, the CNS penetration is acceptable, and these patients can have responses in CNS, and the responses are fast and can be durable. So with that, I'll stop, and we can go to panel discussion.
Yeah. So thank you, Dr. Ashish. And I think it was an interesting case. And I'm sure there are questions. So I think let's proceed to the panel discussion. And we have Dr. Ullas Batra to moderate the session. And everybody knows that he has a large experience in managing lung cancer in India. So Ullas, over to you.
Thank you, sir.
Yeah, the other panelists, Dr. Vijay, Ashish, Dr. Bishwas, and Dr. Santiago.
Do I share my slides, or how does it go?
So you can share your slides, sir, if you want.
Fantastic. So I think whatever I had to say has already been discussed on the panel, has very elegantly been discussed by Professor Santiago and then by Ashish. And we are 15 minutes late. So shall we call it off, Ashish?
No, sir, we are all waiting to hear you, sir. We still have some time.
No, I'm going to ask you questions. Okay. So we have our panelists over here. We have Dr. Vijay, Bivas, Ashish, and Dr. Santiago. And I'm the only dwarf among all these giants, actually. So let's start with the panel discussion on MET exon 14 skipping mutant non-small cell lung cancer. And my first reactions when I actually, whenever I have spoken about MET, I'm sure Dr. Santiago, you will not understand the two Bollywood things which are going to come up, but I'm sure Ashish and Bivas and Vijay are going to say to learn to know about it. So I mean, MET for us is as old as Jab We Met, and Jab We Met got released in 2007 or 8. But the story of MET actually started way back in 1984. Since then, it has been an unmet need. But over the last couple of years, I actually believe that we have finally met our match. So my subsequent reactions from Jab We Met starting to this, that is an old story right now. And the latest story is the latest Bollywood thing which is going out. How did Anant Ambani met Radhika Merchant? And I really hope like Anant Ambani has met Radhika Merchant. We have, Ashish, no comments on this. We finally hope that MET has finally met its match in either of the three MET TKIs that are there. So that was just to get the thing going. Now let's start with the diagnostics part of it. And this is a pie diagram of NGS in lung cancer. This is a Western data, which is basically showing KRAS of around 30%, EGFR around 21%, and MET is around 4% here. This was a vision study, basically, which said that in this study, very important is that they took all histologies patient. They took squam and they took adeno and they took adenosquames also. And again, as we see over here, that histology adenocarcinoma was only 80% in all the population. So I'll start with Vijay. Vijay, are you here?
Yes. Hi, Ullas.
Yeah, Vijay. You know why I'm going to ask this question to you first. So have you been testing for lung cancer now in squamous cell carcinoma? Do you test for that now?
I have been, yes.
Since the last webinar that we have had?
Correct. So where Ullas is coming from is that the squamous ones, I was only doing PDL1 and not NGS. And I think there are a lot of discussions whether it could be adenosquamous, whether it's a pure squamous, and whether we should be doing NGS in all of them. And in fact, having said that, I have identified one EGFR on a squamous, and that patient is on osimertinib. So thanks for that, Ullas. But yes, I have been doing.
So that thanks doesn't go to me, Vijay. It goes to Kumar Prabhash, who has been a very vocal proponent of that. Ashish, I heard in your presentation you are doing in all the patients squam.
Yes, sir. So now all NSCLC we do NGS.
Okay. Whether smokers, non-smokers, whether either in a chronic smoker you will do an NGS.
We do, sir. We do.
You do.
We
Okay,
do.
fantastic. Okay, Bivas.
Yeah, same. Initially, I used to do on non-smoker, maybe female, maybe adenoscomas, but now I'm doing all pure scomas also. Again, for MET exon 14, also for KRAS and others.
Okay, so I mean, same here. Professor, what is your outlook towards this? Do you do it in only non-smokers, small biopsies, or you do in all smokers also with squam, you do NGS?
No, we are doing in all non-small cell lung cancers, regardless the smoking status. And even we are now trying to do in stage 3. And of course, with the new opportunities in the adjuvant setting, also we are trying to expand to any stage. But now we are doing stage 4 and stage 3, all histologies, regardless of smoking status.
So I totally agree. I think we should be doing NGS in all patients of lung cancer, not only to give target therapies, but also when not to give immunotherapies. Because we know if you have a EGFR, ALK, or a non-smoking related cancer, we may not actually, immunotherapies may not work. And I think we are, Tata has their own data. We have also our data. We have got 4% of EGFR and we have got 2 to 3% of ALK. And we have got, in fact, a very nice case. This patient, 2 patients, one with ROS and one with ALK. Both of them had adenosquam to start with. We gave them ALK TKIs and ROS TKI. On progression, the only component which seems to be progressing is squamous. So from adenosquam, it came to squamous, and now squamous is the one which is going. So I think we should be doing NGS testing in all the lung cancers. When I tell my patient, the percentage goes down from 30% to, okay, fine, something may come in 10%. But in India, we have a lot of companies which are offering a standardized rate for NGS. So I think getting it over there should be, I mean, we should be doing. So that's the first message that we wanted to say. And this is what the NCCN guidelines also say that we should be doing in squamous as well as non-squamous over here. Second, let me go to Ashish first. Ashish, so when you do NGS, you're looking at splicing mutation, point mutation, amplification, or fusions. What exactly are you looking at?
Actually, thankfully now we don't have to choose all this because our NGS panels do look at each of these. But that's, I think, is important to look at the test what we order and what platform you're using, because I know in India there are various panels starting from 6 genes, 14 genes, 42 genes. So we have to talk about this to a pathologist, and we wouldn't want to miss any of these, even though exon 14 skipping is what we all want to see. But as Professor showed in this talk, even amplifications can be used to target this.
Can I ask you a question, Ashish? Let's say you have a MET amplification of, let's say, CG and copy number gain is 11 or 10. In the first line, would you be in a PDL one of, let's say, 20%?
No. I mean, so basically, what I do with this information, that's another thing. But I think what I was trying to say is that our test should be capable of picking up these amplification. You may not act on it in the situation what you just mentioned.
Correct. So what happens is in the WhatsApp group, that's the first thing which comes over there. You know, somebody with a MET amplification, what would you do? Would you do OC plus capmatinib or OC plus tepotinib?
Right.
There, and we were actually a part of the trial in which Pembro plus capmatinib was being used, and that trial was closed for futility. Actually, there was a lot of adverse events in that. So I think important thing is, as far as the label goes, we have to look at the exon 14 splicing mutation. But as you rightly said, in the NGS, I would like to have a look at everything. Maybe use it in the second or third line, the MET inhibitors, not in the first line. Do you agree, Bivas?
Sir, I think all has been discussed. So amplification mostly in the post-TKI setting and later lines. And again, it's a dynamic situation. So if I have an amplification, I may need to recheck again during the rebiopsy setting. But
Correct.
no use in first line, right?
So Bivas, staying with you, what is the test you use? Do you use ALK IHC or do you use the IHC, FISH? How do you do it in your setting?
So
both at TMC and now at Apollo.
So TMC, we used to do RNA-based sequencing for all the fusions and mutations. That include all. And for a non-affordable one, I do only the EGFR, ALK, and ROS1. So it's a customized depending on patient to patient. And but I'll whenever the opportunity, I'll use the whole RNA-based sequencing, at least for the broad panel.
If there are any residents listening to this, will you advise a MET IHC for them?
No.
Okay, so I can put a no across over here. Will you put, I mean, either a MET FISH, which look at the amplification, is absolutely okay, but I think this is the test which is supposed to be.
Yes, for skipping mutation, it's an RNA-based, especially RNA-based sequencing. Right.
Absolutely okay. Now let me come to the liquid biopsy capital of India. That is Vijay Agarwal, Bangalore. So Vijay, liquid biopsy, when do you use that? I mean, and what is your experience till now been?
Yeah, so I tend to use post-TKI progression. I tend to use liquids, but upfront it is all tissue biopsies.
And how many patients have you used liquid biopsy?
So I probably do about 4 or 5 a year.
Okay, so you are exactly on the same boat as we are.
Yeah.
You are away from the the liquid biopsy capital in Manipal, I guess. Okay, Professor Santiago, liquid biopsy. What is your take on that, and how do you assess in your clinic?
Okay, I'm a real fan of liquid biopsy. I have to say that during the Vision trial, I included 8 patients myself, but I tested more than 300 patients. So they were covering for liquid biopsy. So and I was amazed of the amount of information I received. I mean, many patients didn't have MET exon 14, but I were able to detect many other alterations. So for me, participating in this trial was an amazing experience to check for patients that were first, second, or third line. We were using liquid biopsy in parallel with tissue biopsy. But in the reality of my clinical practice, we need to take on account the costs of the testing, etc. So I have to say that if tissue is available, we do NGS in tissue. But particularly in this trial, you had patients that were positive in tissue, but negative in liquid, or the opposite. So in fact, there would be a percentage of patients that you miss if you only do tissue. In an ideal world, I would like to do both things for all my patients from the beginning. There's a particular situation where I have, for example, I receive many second opinion patients, and sometimes they don't bring the tissue, but I can do the liquid biopsy the day I visit them. And some of the technologies for liquid biopsy are very fast. For example, some of them you can have the results in 2-3 days. So this is amazing when you can have a patient and detect that he has an EGFR positive tumor in blood, or a KRAS tumor. You can offer to participate in a clinical trial or something like that. So I would say that I mainly base my diagnosis in NGS in tissue, but if I have the opportunity, I also try to do liquid biopsy in parallel, and I also offer liquid biopsy and any kind of progressions to avoid secondary biopsies that sometimes is invasive for patients. But of course, there are things that you can detect in the liquid. No, you can see the PDL1 in the liquid. You TMB in liquid. Well, we don't use TMB too much, but you can. You may have a calculation of TMB in liquid, but yes, I would say that 80% tissue, 20% liquid.
So if I can have to summarize, can I say we all will want to do a tissue and liquid biopsy concurrently if money is not an issue? Is that right? And at Resistance, I think most of us will do a liquid biopsy because patients may not agree. But a combo of tissue and liquid biopsy will be the ideal. Ashish, do you agree?
Yes, sir. So, but then many times I'm not sure, like, because in liquid biopsies or even in NGS for that matter, are our pathologists who are reporting this, are they very sure about what is the cutoff? What is amplification, number of read counts, copy number? So because the moment sometimes they'll say, because as a clinician I'm asking for, look for this, they'll say, okay, there is something there, but I'm not sure how significant it is or what is the cutoff.
Let me rephrase my statement. I will like to do both liquid and tissue biopsy from a genuine, reproducible and a good lab, ideally.
Yes.
You're right. I mean, I have always said this.
Because at least in India we are looking at drugs which are very expensive. So I wouldn't want to be using when I'm not sure that this is the right biomarker.
Absolutely right. So I mean, we do it in house, or we send it to one of the people, since it is not this symposium. But I think we need to invest, as in India, we need to invest in a liquid biopsy, because in the future, liquid biopsy, whether we like it or hate it, it is going to come. Like NGS has now become standardized. When the initial thing came, we were not sure about the NGS. Remember, we used to have this discussion about T790M ddPCR. 0.02%, 0.05%. Then we learned how to use and interpret the test. Similarly, I think we as medical oncologists and the molecular pathologists need to invest in liquid biopsy, need to invest RNA component of that, understand the intricacies of that, and then take it from there. But as a concept, I think the test is fantastic, but a good lab and not the run-of-the-mill lab. And sorry to say, not the coupon labs. Coupon labs just don't do a good job of that. Okay. So let's say let's just put up a case. Ashish, use this is almost similar to your case. Let's say you have a patient in which it's a stage 4 lung cancer. You have started EGFR all-case negative. You have started with 1 cycle of chemotherapy or 1 cycle of chemoimmunotherapy. Then the NGS report comes, and the NGS report comes as MET exon 14. Will you continue with, because we have data in both first line and second line, will you continue with pembro and chemotherapy for 4 cycles, and on progression give a MET TKI? Will you stop immunotherapy and give MET TKI? That almost similar to your case. And I also have a question. Normally we say that after immunotherapy you would like to give a 2 to 3 months gap to avoid pneumonitis. I didn't see that in your case. So your take on these two.
Yes, sir. So that's the so in the first line, actually, patient what you put up on the screen. Some people may even want to just use single agent immunotherapy
Correct.
because PD-L1 you put 70%.
Correct.
So
That is why I put liver meds over here. It's
so
easy.
yes, so I agree with chemoimmunotherapy, even if we know that there is MET exon 14 skipping, because it's not that these patients don't have response to immunotherapy. Many of them are smokers. They may have other biomarkers which may predict response to immunotherapy. And regarding your second question, when would I bring in a MET TKI? So that depends on how my patient has responded to the chemo or immunotherapy. And I generally, as a rule of the thumb, don't change something which is working very well.
So only
So
one cycle has been given, Ashish.
yeah. So then in that situation, I would continue. I would continue for 2 or 3 and then do a scan.
Okay.
And if it's working, I wouldn't change.
Okay. Bivas?
Yeah, so sir, as a practice, I don't start on immunotherapy till I have the full NGS. So I give the cycle 1 chemo, I wait for the NGS, then I take the call.
But
So
it
this
has been done by me.
right.
I started. I also don't do it, but I have started. Now, tell me, what will you do
So
now?
right. So as Ashish said, he has used. So I have that experience with an INC 280 where there is a very toxic trial of capmatinib with pembrolizumab, the same trial you had, and that has to stop in between. So I have skepticism what to do. Maybe we have a good data and it's a driver mutation. I want to switch to first line TKI, then keep the IO for subsequent line.
Okay.
And maybe I'll give cycle to chemo and then switch to TKI. I'll give some gap between the IO.
IO in this. Okay, fantastic. Vijay and then Professor Santiago. Vijay?
Yeah.
So one cycle chemo immuno, MET exon 14 report has come. What will you do now? Oral TKI, continue chemo immuno, or what?
No, I would switch to MET inhibitor. You give only one cycle.
That's
It's not
okay. Only one
much. You got a driver. You need to inhibit the driver.
So you will give it because you believe that you should give the driver, or you believe that or any other reason you
So
believe that
there is some
immunotherapy won't act in this.
There is some data that PD-L1 is generally expressed higher in MET in the presence of MET skipping mutations, and immunotherapy does not have the same kind of effect that it would otherwise do in the absence of a MET inhibitor. So I would probably switch to a MET inhibitor.
MET inhibitor. Okay, Professor Santiago, and then I'll give you my comments on that.
Okay. Yes, as Beva said, I would try to wait for the results. This is like a religion for us, but after that, sometimes it can happen. No, you may need to start very fast. You may think that this patient has low likelihood to have an alteration that can be treated. But I would agree with BJ and change to MET inhibition. For several reasons. Side effects of chemotherapy are not comparable with the potential side effects of TKI. Probably patient would be happy if you can skip the chemotherapy or save for later. I was very concerned when I started the division trial for patients that have been previously treated with immunotherapy of the potential toxicity of using TKI after very close to immunotherapy. And I remember a particular case. It was at the start of the COVID outbreak, and he had like a pneumonitis-like problem. And we were not sure if it was COVID, it was progression, or if it was immune pneumonitis. No, and I was really insisting to the medical monitors and the team that it might not be. But this has been analyzed from the Vision trial, and they haven't found any particular increase of toxicity after the use of immunotherapy, PD-L1 and MET inhibitor, tepotinib. And in fact, there is also a potential synergism between MET inhibitors on the tumor microenvironment and the immunotherapy. And so I would say that, yes, I think that the patient has most chances to benefit from MET inhibitor and the side effects are less. So I would change and save chemo or immuno for later.
So I would also probably agree, only for the simple reason that I would curse myself if a patient with the oral drug progresses and doesn't take, because 30% of people don't take a drug. So oral drug, people will be more happier. The PFS in the first line is more better. The duration of the response is more better. You don't have to come and take immunochemo. That is the only reason why I will, that's the major reason why I will shift to a MET TKI, and then probably give immuno in second, third line. That's my reason, but I mean, absolutely okay, because MET, BRAF, and KRAS are the only three tumors in which immunochemo also still works. And as Ashish said, if the patient has a good symptomatic improvement, I can continue with that also. So there was just an hypothetical case. But the best thing to do in this is, as what Biva said, please don't start immunotherapy till the time you have had the NGS results. And the NGS results can come very fast in our labs. Any special preferences, Vijay? Forget that this is a Merck symposium about capmatinib or tepotinib. I'm sure all of us will not give crizotinib. So just anything which is 1 rupee cheaper.
I mean, to be honest, after listening to Professor, I think I mean till prior to this meeting, I didn't have a preference, but after listening to him, the comparison data, I think tepotinib would be my choice.
Okay, Bevas?
So I have experience with all three. The Savolenti through Savannah trial, no toxicity, both capmatinib, tepotinib. So among the capmatinib, tepotinib, both is approved. I don't have a specific choice. Which one is cheaper for me, I'll go for that.
Okay, 1 rupee cheaper. Ashish, half an hour, half 50 paisa cheaper.
No, sir. I think I mean the professor did show some MAIC during his talk, and they both look like good drug. And in terms of the PK/PD, there may be something to favor tepotinib.
So I think in the MAIC thing, which is shown, tepotinib is definitely slightly better. Although again, these are statistics, But in the absence of this, and if it is 1 rupee cheaper, I will also use tepotinib. In addition, it has a liquid biopsy is also valid in this, and brain mets also in this. So I think I will probably also go for tepotinib. Brain mets, Vijay, how happy are you in giving tepotinib in an asymptomatic brain mets patient? Would you want to irradiate? Would you want to give SBRT? How will you want to go?
So generally, say if the patient has one or two lesions, I'm not averse to giving SBRT because the toxicity from SBRT is not much. But clearly, if there are multiple lesions and I need to give whole brain, I might take a chance and say let's give MET inhibitors and see if there's a response before I give whole brain. But giving one or two lesions, SBRT is something that I'm not averse to at all.
I forgot Bangalore is also the SRS capital of the country, in addition to being the liquid biopsy capital and the HIPEC capital.
I don't go near HIPEC, so the other two are fine.
Okay. Ashish, let's say 4 lesions, small subcentimeter lesion, patient asymptomatic. SRS or directly start with a MET TKI?
I mean, if patient is asymptomatic, I can watch him every 6 weeks with MRI. I'm comfortable doing the TKI.
Fantastic. Bevas?
So I think for asymptomatic TKI, for mild symptomatic, I'll manage a steroid. If improvement, TKI. For overtly symptomatic, I will radiate followed by TKI.
Fantastic. We are all anti one particular this thing, which is okay. So I think I agree with Vijay also. I mean, the radiation oncologist will come and tell us to just give SRS to 2 lesions. But my answer always has been, why do you want? What are you going to palliate? Ashish has just sent an article. Ashish, what have you sent that? I cannot read this.
No. I'm just sharing that this thing about immunotherapy doesn't work in MET exon 14 may not be totally true, because we know there are other players like TMB, TP53. And yeah, so we always have, I mean, the thing about immunotherapy is the responses can be really durable.
And I think there is a paper on lung cancer also, physical lung cancer.
And that is what actually, so it may be a good thing to try if we can, at least in the first line.
Okay. Professor Santiago?
Yes, regarding that, I also agree with Ashish that we don't really have solid data on that. I mean, there are hints of worst efficacy of immunotherapy, at least when we compare to other tumors or other patients with high expression. Now, we can expect this great effect that we see in other PD-L1 more than 50, but particularly for smokers, I think immunotherapy may have its role even in these patients. For never smokers, I'm more skeptic in general for immunotherapy all type of, I mean, with or without mutations. I haven't seen very good responses in never smokers for immunotherapy. So maybe for me, it's a very simplistic approach, but smokers, it can happen also in BRAF mutations that can be in smokers and never smokers. Yes, that's a feeling I have, that I'm more happy to try immunotherapy if the patient is a smoker than a never smoker. But I would say that it's not fair to completely rule out the possibility that immunotherapy benefits these patients. But in my vision, if you have a very good targeted drug, it has happened in other driver mutations. No, you can use this targeted drug in the first line and then save the other potential treatments for second or third lines.
I think a fantastic point by Ashish also was that immunotherapy can give you long-term survival, the plateauing of the curve. So that was a point which Ashish has brought up, which is very nice. And what the professor also said was right. I think smoking, non-smoking is something which we have to bring it in our day-to-day practice. We think about it, but somehow we don't really put it across. But a fantastic point, Professor. There are two questions which I will take it in the end. Safety profile, Vijay, like it, adore it, fill it, shut it.
Yeah, I mean, it's not too bad. I mean, we've had worse with other TKIs from the face of it. I mean, I've got very limited experience in using this, but from what I'm looking at it, I think edema and things like that should not be a major problem.
Reasonably okay. The only thing which the thing is, I mean, a pseudo elevation of the creatinine because of the MAGE inhibitor enzyme inhibition. Don't get bothered about that. I mean, that was one thing which came. Edema, professor told what we use is we use salt water restriction, foot elevation, given Lasix, but normally it subsides to what Ashish also said, around 10 kgs. I mean, my increase in weight gain of the patient as a doctor has never been more than 5 to 10 kgs. That's what it subsides at. It's not like lorlatinib, which gives you 20 kgs increase. So reasonably good drug. Dosing schedule, I think we'll step up that. This is something which I want to show. And I'll go for this. This is our data of 478 patients of NGS that we have seen. Our EGFR rate is 25. Our KRAS rate is 14. With the West, it is 30. Our rate of MET exon 14 is 4%. Only MET exon 14. MET amplification we have not said. This is the diagram again, Venn diagram, what we are showing over here, which has shown the thing. Now here is where our data. This is our and TMH combined data. We have had 49 patients. First line treatment was given to 52 patients. 7 patients did not take treatment. First line TKIs were given to 14, and then they subsequently took chemotherapy in 8 patients. First line chemotherapy was predominantly given in 28 patients, and then they took second line 14 patients again they took, and then third line 5 patients took TKIs. So predominantly because a lot of people start with TKIs and it was COVID time and all. It's last 2-3 years data. This is the first line data of the median survival PFS, which is around 11.9 months. The first line survival PFS data for chemo was around 5.9 months. So 12 months in the first, and this is both capmatinib and tepotinib. And this was second line. In second line, it has not really done well. I mean, that is why my point is 7.7 months versus 4.6 months. So this is one, although small numbers, 14, 15 patient numbers, and the median overall survival has not really been reached. And in the first line chemo, it was around 22 months. So by and large, exactly the similar results what we have got in the trial settings. We have already given this for publication, and hopefully this should get published over there. There's one question in the chat box which states, how do we sequence therapy when we have both KRAS 12C and MET exon 14? I think it's easier. We don't have a trial for KRAS 12C. We will give MET exon 14 and then we'll see what to do. Please don't combine sotorasib or this thing with this. It's going to be, you're going to be friends with a gastroenterologist, I guess. Second question is, Bivas, does the amplification of MET still confer IO resistance?
Not to best of my knowledge. There are some retrospective or post-hoc analysis, but there is no prospective data that shows that MET amplification confer IO resistance, to best of my knowledge. But there are
Ashish, you have sent some new paper?
No, that's something not related to. So I think these things may be a prognostic biomarker. What you're saying? Okay, if you have MET amplification, overall they may do poorly, even with immunotherapy as compared to no MET amplification. Yeah, but but that's
we did a study in which we did for EGFR around 230 patients. We did NGS of all those people. People who had concurrent MET amplifications, as Ashish rightly said, did poorly. So these had lesser PFS or I think 6.8 months was the PFS in that, and the other hand, it was the PFS was 15 months. So as Ashish very rightly said, MET amplification will do poorly, but whether you give OC plus capmatinib or OC plus tepotinib at present at diagnosis, we don't know. We all know in progression, you can go ahead and give that, as the Savannah and the other studies have shown over there. So that was it from my side. Professor, any words from your side? Otherwise we'll close it. Professor?
No, excellent discussion. I'm really impressed by the big efforts you are doing in testing your patients, and we have all these questions on our table, no? Particularly for the topic of side effects of edema that we were discussing. I would just like to strain a point, no? Is that this is not a side effect, but a main effect of the drug. I mean, when you block MET, you have this effect. So the only effective way to deal with it is to stop the MET inhibition. I mean, the holidays of the drug. And whenever the patient has a very, very well-established edema, it's difficult to go back. So it's very important to detect it early, to try to prevent it with measures, physical activity, physical therapy, etc. But if you really are dealing with the edema, I would stop for a couple of weeks or something while you do all the therapy possible to remove the edema, and then restart with a reduced dose. This is, in my experience, what works best.
Fantastic. Ashish?
I think that's a very important comment he made. I think we should look at it like lymphedema, how we manage patients post-surgery, right? So prevention should be the aim. And once the edema is already set in, there's very little we can do. So these compression bandages, compression therapies, involving your nurses, education, I think all that is important.
I think prior to that, Ashish, people should know the side effect of the drug. So that is what happens when you have great minds on the panel discussion, so much of learning. And the main point which I would like to learn is it's not a side effect, it's a main effect. So thank you, Professor Santiago, for that comment. Thank you, Vijay. Thank you, Bivas. Thank you, Ashish, for a wonderful discussion. It has went better than what I thought it would go. Thank you for all the great points that you have said. Thank you. And I hand it back to the organizers. Thank you.
So wonderful, Ullas. As always, you've done a good job of highlighting all the situations that we face in the real world in managing lung cancer patients on a day-to-day basis. So we go to the last session, a talk by Professor Santiago on MET amplification and its management.
Thank you very much. And so now we will try to get into this interesting topic that it's MET amplification. And I think it might be more delicate, because as mutations can be there or not be there, we can detect it or not. MET amplification is a continuous variable. Okay, we can see in different intensities of MET amplification. MET amplification can be a primary driver on itself, but also can be a mechanism of resistance. Let's see what we know until now on this topic. Okay, so as we mentioned, this regulation of the MET pathway can drive oncogenesis. Okay, as we've seen, if we have the amplification at the gene level, an excessive number of copies of the gene, then we will produce an exaggerated number of proteins that will be in the membrane, and this will cause an exaggerated activation of the signaling pathway, driving to metastasis, proliferation, and survival. And so if you think about what we explained about what causes the skipping of the 14 exon, it's the same. We will have the same result. Too many MET proteins in the membrane. Okay. So next slide, please. Okay, as we see, we can detect this this alteration can be seen in two different situations. One, as a primary driver. Some tumors, some non-small cell lung cancer patients, their tumors only have this alteration and do not have any other concomitant driver, oncogenic drivers. Okay, so, and it's around, we don't know very well. It can be from 1 to 5% of the patients. But interestingly, when you look at MET amplification in patients with MET exon 14 skipping, they can be concomitant. Up to 15 to 20% of the patients have both at the same time, MET exon 14 skipping plus MET amplification. Okay, but we also detect this MET amplification as a mechanism of an acquired mechanism of resistance. Especially, it is well described in EGFR TKI. When we were using first or second generation, we detected in the 5% of patients. But now that we are using first-line osimertinib, we see that up to 15 to 20% of the patients that are progressing to osimertinib have this mechanism of resistance through MET amplification. And this has led to a very interesting development of drugs and combinations. No? Then we have amivantamab, that is an antibody, bispecific antibody that binds to EGFR and MET at the same time. So the people who developed this were, of course, thinking to try to avoid this secondary pathway to be activated. But it also appeared in the resistance to other TKIs like ALK, ROS, or RET. And as it was, there was a question in the panel, no, that if MET amplification can also be a mechanism of resistance to immunotherapy. It's been said that it's not described like this, at least, because immunotherapy is not only one pathway. No, it involves many pathways. You have the immune immune cycle with many steps. But I would say that MET is an important receptor of the tumor microenvironment. So there might be a role of the combination of immunotherapy plus MET inhibition, but not to target one amplification of the tumor, but to target an amplification or MET activity in the tumor microenvironment, in the cells that are surrounding the tumor. Next slide, please. Okay, so what we know is that MET inhibition may prolong overall survival compared to systemic therapy or immunotherapy in those patients with non-small cell lung cancer and these MET alterations. We know that. I mean, you can have here a summary of what happens with MET exon 14 skipping, but also MET amplification or all the MET alterations together. So it seems that when you have an alteration of MET, using targeted therapy against MET is usually more effective than regular chemotherapy or immunotherapy. Next slide. These are retrospective data. Next slide. And how do we detect this MET amplification? Next slide, please. Okay, this slide has already been shown. We can test in the tumor, but we can test in the liquid. And it depends on the, as I said, this is more difficult to ascertain than mutations because mutations are there or are not there. But amplification have a cutoff point that you have to decide. And depending on the technique you use and the material you analyze, you may have different results. Next slide, please. As we said, tissue biopsy has demonstrated to be more sensitive than liquid when you are looking for MET amplification in patients who have progressed to EGFR TKI. Okay, it does not mean that you can do by the liquid biopsy, but it seems that it's more easily detectable or more accurate to detect the MET amplification in the tissue in rebiopsies of patients after progression to EGFR TKIs. And in order to do that, the gold standard is considered the FISH, because the FISH, you can see all the copies of the MET, and it's maybe easier to interpret. But it could also be detected by other techniques, like RNA-based NGS, etc., that can quantify the number of MET copies. But the gold standard, at least, and for trials that are trying to deal with this mechanism of resistance, we consider that MET amplification by FISH is the test that predicts a better benefit for treatments against MET. Next slide, please. Most patients with non-small cell lung cancer are willing to undergo tissue rebiopsies, but physicians may be unwilling. Well, this is a very important issue. When you ask the patient and you explain them that if you do the rebiopsy, this will lead to a better understanding of the disease changes and that you can select your treatment, they are usually willing to do the new biopsies, but it is us, the doctors, that we need to change our minds and to be convinced that these rebiopsies are worth it. Of course, we don't want to make unnecessary procedures to our patients. Of course, we don't want to make them undergo invasive procedures, but it is really important. I mean, in our case, we are usually willing to do surgical biopsies even because we need to obtain enough tissue, good quality tissue. And as I said, the patient usually is more willing than us to do these procedures, but that are really important. We must understand the changes of the tumor so we can decide the new treatments. Of course, we need to evaluate the risk carefully. We don't want a patient to die in the procedure of a rebiopsy, but it is a very unlikely outcome of this decision. Next slide, please. Next slide. So the Vision trial had a third cohort. We were discussing cohort A and cohort C, but there was cohort B. And cohort B was designed to evaluate the efficacy in patients with high-level MET amplification detected by liquid biopsy in this case. So we just mentioned that for MET amplification as a resistant mechanism to EGFR, the best test appears to be FISH in tissue. But for the data we have regarding MET amplification as a primary driver, it was tested by liquid biopsy, okay? And there was a cutoff point that had to be more than 2.5 gain copy number in the liquid biopsy, corresponding to the same fraction of patients. I mean, this criteria, this cutoff point in liquid, 2.5, was equivalent when we used this criteria in tissue, and the cutoff was 10 copies in the tissue. Okay, it's always tricky when you try to make this parallelism that how will I detect the MET amplification in the liquid? Because of course in the tissue you may have the regular number of copies, and then you can have this multiplication 10 or plus copies is very of course solid, no, when you see this multiplying number of copies. But in liquid it is different. It's very difficult to do that. But here they evaluated the situation and they decided that this cutoff point in liquid was similar to plus than 10 copies in tissue. Next slide, please. So what happened here? So 2.2% of the patients pre-screened using the GARDAN were positive for MET amplification and negative for MET exon 14 skipping, because the ones that were positive for MET exon 14 were allocated to cohorts A or C. And so that meant that more than 3,000 patients were tested. And finally, 32 patients were screened for inclusion in cohort B, and only 24 patients were enrolled and received tepotinib, 10 in Spain, a couple of them were at our center. And at the moment of the cutoff of this slide, 2 patients continued on treatment. Please, the next slide. So what are the characteristics according to the treatment line? Well, As you can see here, these are not so an elderly population. The median age is 66 for first line and even 60 for second line. And you can see patients as young as 38 years old, no, in the second line range. So most of them were male and most of them were smokers. Okay, so very different profile, no? This is a different disease. I mean, it's MET, but the MET amplification as a primary driver has a different epidemiology, okay? And it appeared mainly in adenocarcinoma. They didn't found almost very few squamous. They appear in the third line and neuroendocrine carcinoma, but mostly adeno in this case. Okay, so there were the number of this cohort is small. No? As you can imagine, we cannot draw many conclusions. Next slide, please. What are the responses to tepotinib for this MET amplification? Well, you can see here, there was a 71.4 in the first line overall response, but in the second and the third line, it dropped to around 30%. So disease control rate was the same. So it seemed that in the MET amplification, it was very important to use the first line where the patients that had derived the most benefit, probably because after second, third line, new other mechanisms were included in the disease. Next slide, please. Well, the overall survival of the patients included in this cohort, very low numbers, but as you can see, in the first line were 14.3, second line 7.5, and third line 2.6. So again, the story here seems to be different in that the tumors that are driven by MET exon 14, where tepotinib seemed to be useful in any line. Here, it seems that first line it's more important, or the efficacy of this kind of drug is especially good in the first line. Next slide, please. Okay, regarding adverse events, well, you can see that some adverse events led to dose reductions, some treatment interruptions, and permanent discontinuations. But an interesting thing is that there was less edema in this population. And an important aspect is that this is a younger population and probably more physically active population. So this seems to be a prognostic factor regarding the edema. Next slide, please. Well, a very interesting exploratory analysis of baseline biomarkers and response to treatment was done. And as you can see, the efficacy was most pronounced in patients treated in first line and with adenocarcinoma histology, and also patients with clinical benefit had lower tumor load than patients without clinical benefit. So patients that had a very big tumor burden were more prone to have faster progressions to the disease, and the durable responses were most pronounced in patients with clinical benefit and with a more than 60% reduction in the tumor size. So MET amplification is also an aggressive disease. It may appear with a big tumor burden, and this is cause a bad prognosis for those patients. Next slide, please. Again, a very interesting analysis of the biomarkers and the response to treatment showed this. When you detect the amplification, this amplification can be focal or non-focal. And it seems that non-focal amplification derives less benefit than focal amplification. If you can see here in the heat map, the dark purple patients that are mainly in the patients with clinical benefit column are the ones with this focal amplification. Probably when you have this non-focal amplification, it's a bigger part of the gene that is amplified, and then it's not so clear that is the MET alteration that is the one that is driving the oncogenesis in these tumors.
And they found that baseline retinoblastoma wild-type status and the diploidy of the MYC gene were also better outcome signs, and that patients with low ctDNA burden had better outcomes than those with high ctDNA burden. And this is logical because ctDNA burden is probably related with total tumor burden, and we've seen that. One important thing and a very interesting topic when we were discussing the use of liquid biopsy is that if you could detect an early molecular response in the following monitoring liquid biopsies, was related with better outcome. No, so those patients that after 2 weeks had a very nice clearance of the amplification in the blood were the ones that were having the best responses. Next slide, please. In conclusion, tepotinib has anti-tumor activity with manageable safety profile in patients with non-small cell lung cancer with high-level MET amplification detected by liquid biopsy. In this case, it was Guardant 360 testing and more than 2.5 gene copy number in the blood. And that efficacy appeared most pronounced in previously untreated patients who had a notably high overall response rate of about 70% with long duration of response, that more than 1 year, and long median overall survival, that 14.3 months. And that tepotinib demonstrated clinical activity in patients with high-level MET amplification as a primary driver that where in this population, chemotherapy and immunotherapy in retrospective data are very poor treatments. Next slide, please. Okay, let's have a couple of words about the amplification of MET as a acquired resistant mechanism. Next slide. Well, I just wanted to pinpoint you this very recent article that was very interesting to me because, of course, you have said that before, and I have done it myself, off-label use of combination of EGFR TKI plus MET TKI or ALK TKI plus MET TKI. No, when you have these patients, they are progressing to the original driver inhibition and they develop this MET amplification, your thinking leads to I should block both pathways, no? And you can try it off-label based, patient by patient, and you can read and see clinical reports published everywhere. But this group, they did a very interesting effort and they summarized with 41 patients that had different drivers that have been treated with their proper TKIs and developed resistance based on MET amplification. So they treat them with chemotherapy or with a combination of TKIs. Next slide. What did they found is that the response to the dual TKI and MET combinations were excellent. As you can see here, many of the patients had reduction in their tumors, and also the safety of these combinations was quite good. So something that we were doing in a individual basis, it's now at least retrospectively shown to be a sound strategy, even for EGFR, for ALK, or for ROS1. And they were including MET resistance, not only the MET amplification, but also MET exon 14 mutations. MET exon 14 skipping mutations can appear as a secondary driver in EGFR progressing to osimertinib, for example, or even MET fusions, which are more rare and were mentioned at the beginning of the topic. Please, next slide. What do we know about the use of tepotinib in patients in this situation with MET amplification as a resistance to osimertinib? Next slide. We have a trial, which is the INSIGHT-2 trial. I also participated as an investigator in this trial, and it was an open label 2-arm phase 2 study. So patients were were included if they had metastatic EGFR mutant non-small cell lung cancer that have been resistant to first-line osimertinib, and they must have the MET amplification detected by FISH with plus more than 5 copies, or by liquid biopsy and more than 2.3 by a different test, not the Guardant, but the Archer. And what we've seen is that they were allocated, well, first to tepotinib monotherapy, but these patients were not working very well, and then the combination. Next slide, please. Finally, 140 patients were enrolled, 12 were treated in the tepotinib monotherapy. It was very soon noted that the monotherapy with MET was not enough to treat these patients, and the combination tepo plus osimertinib were 128 patients. Then, and as you can see here, well, there was a possibility to be enrolled by FISH positivity in tissue or by liquid biopsy positivity in blood. And as we discussed, these kind of patients are younger, 61, because these are EGFR mutant patients. The number of females is 60%. The smoking history is 70% never smokers. I mean, typical EGFR mutant patients. There was a high number of patients with brain metastases, up to 35%. And the median time on osimertinib was 15.4 months. And the mutations that were included were the typical ones, the sensitive common deletion of the exon 19 or the point mutation in the exon 21 L85 or 8R. And in this case, as you of course can understand, is almost 60% of the patients were from Asian populations with a higher rate of EGFR mutant prevalence. Next slide, please. Well, so the primary analysis for the objective response showed that an objective response of 50%, which is very, very good, I think, in this setting. I mean, patients progressing to osimertinib, or a standard of care should be regular chemotherapy, but the combination offered a 50% of overall response rate. There was a nice tumor shrinkage in the patients, and these responses were rapid because most of them were seen, the partial response in the first CT scan and evaluation after 6 to 8 weeks, and durable, okay, with patients having these responses lasting more than 1 year or more than 2 years. The median duration of response was 8.5 months. Please, next slide. Well, these are the data on PFS and overall survival. And as you can see here, the median PFS is 5.6 months, and the median overall survival was 17.8 months. This is also, we have the data for patients that were positive only in the liquid biopsy. Okay, that this is the number of 31 patients, and as you can see there, well, there was more or less similar data. Please, next slide. We have here summarized the results in Asian population. The overall response rate was even a bit better, almost 60% for patients that were positive centrally by tissue. And the same that was being said. Median durations of response, 7.3. Median overall survival, almost 20 months. Next slide, please. What about the intracranial responses? We've seen that there was 35% of patients with brain metastasis, and intracranial overall response was around 30%. Around 30%, with a duration of the response that was not evaluated, not reached, and the intracranial median PFS was 7.8 months. 7.8 months. You can see here the pictures of nice responses of brain metastasis. The next slide, please. Okay, so what about the toxicity? Is there a problem if we try to combine osimertinib plus tepotinib? Well, as we've seen, as we've been discussing, tepotinib is very selective. So we have the typical effects of tepotinib on itself, peripheral edema, we discussed, hypoalbuminemia, and we have the typical side effects of osimertinib that can be paronychia, etc. The only thing is that, well, there was some more diarrhea, probably caused by a synergistic effect somehow, and we have to take care about the skin problems plus edema. This can have an overlapping complications, no? If you have like paronychia and very important edema, you can have more problems, especially in some patients like diabetic patients, etc. Pneumonitis was rare, fortunately, and we didn't see any particularly signs of concern. Next slide, please. So the conclusions, the primary analysis, when we look at the patients that were positive in tissue by FISH, the overall response rate was 50%. The median duration of response was 8.5. The median PFS was 5.6, and the median overall survival was 17.8 months. This for patients that have progressed to osimertinib, I think is quite good. In Asian population, the data were equivalent. Overall response rate 59.6, and overall survival 29.8. These efficacy outcomes were meaningful also in patients that were positive in liquid biopsy. The better outcomes were observed when there were no co-occurring mechanisms of osimertinib resistance. Of course, we are only dealing with the MET and the EGFR. If there are other mechanisms, it would also cause a rapid progression. And the combination of these TKIs is manageable. And so we can keep the quality of life of our patients when we do this instead of a second line of chemotherapy for this kind of patients. Next slide. Next slide. Well, as a summary, we know that MET amplification can be a driver on itself, can be the primary cause of a tumor, but also can be a secondary resistant mechanism in other tumors with drivers. We know that MET TKIs can be effective in both scenarios. Tepotinib has demonstrated clinical activity in patients with high-level MET amplification as a primary driver compared to regular chemotherapy or immunotherapy not directly compared, but with the historical results we have with these treatments. And the combination of TEPO plus OSI provides a potential chemotherapy-sparing oral targeted therapy for patients that have progressed to first-line osimertinib. Thank you very much.
So thank you, Dr. Santiago, for a wonderful coverage on the topic of MET amplification and how to target it. And I think everybody will share the impressive responses that were seen in patients who progress after osimertinib, which remains so far a difficult situation to tackle when these patients progress. So any questions, comment from my other colleagues? Any questions in the chat box, Dr. Shilpa?
Yes, sir. There is one question about therapy sequencing when we have both KRAS and G12C and MET exon 14 skipping mutation. Therapy sequencing with KRAS, G12C and MET exon 14 skipping mutation. So how do we sequence the therapies?
Yes, it is a very tough question. And we know that concomitancy of drivers can happen, but we may not know which one is the most powerful. I mean, usually biologically, one of these mechanism of action has to drive the disease and the other can help. We've seen that MET exon 14 skipping can be a resistant mechanism to EGFR, to ALK, etc. So but we don't have data on the possibility of combining KRAS inhibitors and MET exon 14. What I would say here is that we have better results with MET inhibition than with KRAS inhibition. And in the absence of better knowledge, I would try first the MET inhibition and let's see what happens with the patient. But probably, unfortunately, he may not respond and he may need some sort of combination that we have not information on yet. I don't know what other colleagues think, but it's a very tough one. Eh?
I totally agree, and I don't think, and I think we addressed in our panel discussion, don't give them together. And I would agree that maybe you have data for the first line MET TKIs. So start with one of the MET TKIs, and then take it. Maybe you can do a serial liquid biopsies. It would be nice to see what is the VAF of that. So I mean, just which of them is driver mutation. Normally, KRAS will come as a resistance mechanism to one of these MET TKIs. So I think we need to look at it in a total time frame rather than having a longitudinal snapshot of that.
Right, sir. Thank you so much, sir. So, sir, I think these were the questions that we have received from the audience as well. Anand, sir, do you have any concluding remarks for the entire session? And we can close this session post that, sir.
I'll just repeat the way Ullas has put the whole thing in a nutshell. It's at least partly the meds seem to have made its match. So even though as a primary driver, it continues to be a rare mutation, but I think unless we look for it actively, maybe it might not be so uncommon. And MET amplification is a secondary driver when patients progress from different primary therapies, also emerging to be at least a partly successful story. So maybe I think we should never give up on these patients. And like the example quoted by Dr. Santiago, that he saw a patient coming back from palliative terminal care to becoming with remarkable improvement with this drug. So thank you very much, Dr. Santiago, Ullas, and all my colleagues for a wonderful session on med science. Thank you.
Thank you. Thank you very much, sir. I thank all the faculty,
Thank
the
you.
audience, and requesting feedback from each and every one of you. And thank you so much for making this session successful. Thank you very
Good
much.
night.
Good night. Thank you. Thank you, Dr. Santiago, as well. Thank you.
Everybody, thank you.
Thank you very much. It's been a real pleasure to be here with you and share. It has been fun, interesting. I've learned a lot. So thank you very much.
Thank you.
Thank you so much, sir.
Thank you so much. Thank you, Dr. Sat. Thank you, Dr. Ullas, sir.